the treatment modality also can be decided basing on the biopsy. Sometimes we don't advise surgery at all if the biopsy suggests that the patient should get radiotherapy or chemotherapy.
But as a surgeon, when do you intervene and say, no, we need to cut it first?
See, most of the times, all the solid tumors, many of the solid tumors, they get cured only if you do the surgery. If the disease stage is not stage 4, up to stage 3, unless surgery should be a part of the entire plan of the treatment, they can't get cured. But there are international guidelines wherein when to do the surgery, when not to do the surgery, when to do chemotherapy or radiotherapy first.
Dr. Muralikrishna, you're such an eminent surgical oncologist. How important is it for us to be having this talk on cancer today?
First of all, thank you very much for inviting me for this podcast. And the topic is very, very important at this point of time, not only for India and globally also. Because with the aging population, the number of cancers are increasing across the globe, particularly in India. So there's a lack of awareness about the cancer, about the causes of cancer, the early identification of cancer, how to get the access to the treatment for the cancer, and what are all the initiatives the public, the community, the people and the government should take to reduce the incidence of cancer. At the same time, how to get the cancer in early stages and get the proper treatment, because this is one of the leading causes of death for the mankind at this point of time. Though it is second to cardiovascular diseases, but it is going to cross the cardiovascular diseases if the same trend continues. So it's a very, very important and very crucial to have such podcasts at this point of time for the community and the government too.
Hello, I am Meenamma. I'm a storyteller and a trainer, and I wish to share my chats with inspirational people around me on varied topics of global interest with the hope that my audience may design a better life from my episodes. Each talk is meant to be an inward journey. Come travel with me today to meet an extraordinary human being, a proud Indian. Do watch this episode till the end and subscribe to Meet Meenamma on YouTube, Instagram and other handles. Welcome friends. Today's episode is special. Features Dr. Muralikrishna Voona, a trailblazer in surgical oncology with over 25 years of experience. As the first qualified surgical oncologist in Andhra Pradesh, Odisha and Chhattisgarh, Murali has founded the Mahatma Gandhi Cancer Hospital and the Research Institute in Visakhapatnam, transforming cancer care into a beacon of hope and excellence. Beyond his clinical work, Dr. Voona advocates for preventive health through initiatives like the Shreya Cancer Foundation and leads the anti-tobacco campaigns in this area. Recognized as an eminent DNB teacher and a legend of surgical oncology, Murali also chairs the Confederation of Indian Industries for Andhra Pradesh, influencing healthcare policies. Join us as we dive into his remarkable journey, insights on cancer treatment, and his vision for the future of oncology care. Murali, it's so wonderful to have you, and I know that you've left a whole bunch of patients to be with me. But tell me, how did oncology happen for you?
So my father is a surgeon, and he worked in the government sector for all the entire his career. So I was watching him operating during my childhood, during my initial years of growth. At the same time, he was my inspiration to become a doctor, because I have seen him working in the rural areas and helping many patients and seeing the gratitude of the patients in their eyes when he used to see the patients. So that gave me a kind of inspiration that I should also do something so that I will get that gratitude from the people. But during my medicine days and post-graduation days, we have seen that the people who are diagnosed with cancer, they were not getting any treatment, particularly in this area from North Andhra. We have seen in Andhra Medical College where we were not treating any patients with cancer properly, and actually we are all sending the patients to a radiotherapy department. when actually radiotherapy was not happening at that point of time.
Oh my God.
We were not even aware what was happening to those patients that who are referred to radiotherapy department in government sector. So then I have seen with my own eyes, and actually I traveled with my aunt, maternal aunt, when she was diagnosed with cancer during my MBBS days, and I have realized that there is no infrastructure, there are no professionals who can treat cancer. Even my teachers, actually, they were not aware of how to treat those cancer patients properly, where to refer the patients. So the people are simply dying, and people are simply not coming to the hospital for the treatment because they don't have the awareness, they don't have the resources, they don't have the infrastructure or doctors to treat them. So many patients used to go to Hyderabad, Chennai, Delhi, Vellore for the cancer treatment. But as you know, cancer treatment, sometimes it may take 6 months, sometimes it may take even 1 year also. Because if the breadwinner is the patient, then they cannot afford. Even if the family member is a patient, the breadwinner cannot stay with them for 6 months, where no one used to get the complete treatment, and people used to die either without treatment or during the treatment because they can't go for the treatment. So at that point of time, I have realized that there is a huge gap because of the problem. At the same time, need is there. At the same, it's a good opportunity for me as also an individual, and something can be done by me for this region. So I chose my career in surgical oncology.
So surgical oncology was always your first option as a doctor?
Because I was a surgeon in that time, during my post graduation, I went to Tata Memorial Hospital for 3 months of training. Then it was very exciting field of science, and I felt that I can make the difference by coming back here to Vizag and treat my patients from my region to a better way.
Murali, this episode is dedicated to your father, to great parents who are role models and teach the children that, I understand that very young age, from college you used to come and watch your father doing surgeries. And that is how your surgical expertise has started. In fact, many of your colleagues always talk that Murli was ahead of us. He started surgery at much before he became a medical doctor
Yes,
fully.
yes.
You already were into surgery. But you must have seen the last 25 years so much of innovation in cancer care, surgery. What are the new trends that you see that are actually very useful? Because when you say cancer, people are very frightened. But as a surgeon, what is the situation today, and what are the new trends?
So, a lot of research has gone into cancer, both at the areas of early diagnosis, even prevention, and treatment modalities, where the advanced treatment modalities are available at this point of time, and where the treatment side effects are less, the cure rates are better, the quality of life of the patients is very good at this point of time, and many patients are living very long with a very good quality of life with a simple treatment also. All these things happened only because of the better understanding about the natural history of the disease, how it spreads, how it gets how it starts in the cell level. Cellular biology understanding has become better. So the treatment modalities also have come like that. Because, for example, if you see the early detection, we have a wonderful early detection methods for breast cancer, cervical cancer, and oral cancers. Particularly, even artificial intelligence is there right now. So it reduce the amount of technology that we have to go take the technology to ground level, rural outreach programs. Second thing is treatment. As for the treatment is concerned, we have a better diagnostics like PET CT scanner, gamma scanner, CT scanner, MRI scanner. All these things happened only because of the technology. The third thing is surgical minimalism. Earlier we used to do mutilating surgeries. Now we are not doing mutilating surgeries. A bone tumor we used to amputate. Now we can do a limb salvage surgery. A laryngeal cancer we used to remove the larynx, voice box. Then permanent loss of voice used to happen. Now we can do a laryngeal preservation. Breast conservations, we don't need to remove the breast at all in the early stages of breast cancer, even some advanced stage of breast cancer. In rectal cancer, we used to do a permanent colostomy. Nowadays, the chance of having somebody having a colostomy is only 10%. So likewise, we have changed the treatment modalities where surgical minimalism and organ conservation is possible. With the multidisciplinary methods, we could able to avoid certain surgeries. Like with chemoradiotherapy, sometimes we can completely cure the patient of laryngeal cancer and we can treat them without surgery. So that's a huge change in that person's quality of life. Likewise, in medical oncology, many people used to die only because of the side effects of the therapy. Nowadays, with the current supportive care and precision medicine, targeted therapy, immunotherapy, these side effects are very, very rare now. So, likewise, in radiation oncology, with tomotherapy, cyber knife, and proton therapy, linear accelerators, now we can treat the patients very, very with a lot of precision,
Precision,
where
target
we
fixed.
don't need to treat any normal tissue all around the tumor. With 1 millimeter margin or sub-millimeter margin also we can treat, so that patients are getting cured without any side effects. So the huge changes have happened in the last 2 decades particularly.
Doctor, for a simple human being, a normal, Indian or a person, what are the symptoms of cancer? Supposing you say cancer, they get frightened, all of us. But what are the symptoms that, we should watch out for, which could possibly lead to cancers? What are the simple things that we can tell our audience?
So any health related problem which is not subsiding with regular treatment and which is lasting for more than 4 to 6 weeks should be suspected to be cancer. In general, for general people understanding, be it a ulcer, be it a lump, be it any change in the bladder or bowel habits, any change in voice, continuous fever without getting the diagnosis and not getting relieved with regular medication, any difficulty in swallowing, any changing in the voice. So all these things which, if they are not getting corrected with a regular treatment in a month's time, should be suspected to be cancer. That's a fundamental principle with which the patients or mainly the referring doctors, the primary physician should have this suspicion. The patients are not responding to regular treatment in a month, so they should suspect cancer.
So, a general practitioner is the first person that we get in touch with. What is the second stage? So, supposing the GP has a suspicion, is a blood test enough for us to understand whether there is a possibility, or what is the second stage of deciding?
Basing on the symptom, there will be a primary simple investigations which are available in the primary health center or community health centers at the district level or taluk headquarters in a government sector or in private sector also. Basic ultrasound, clinical examination, chest x-ray, basic urine examination, basic blood test. Most of the times with common sense and basic investigations itself, the primary physician can diagnose cancer almost to the extent of 90%. Actually, suspicion. Then for the investigation side, yes, they have to send the patient for investigation and evaluation to a tertiary center, where it can be a private center, it can be a medical college cancer center or any institution where there is a comprehensive cancer treatment modalities are available. So this is the process of referral.
So, Doctor, common man, when you hear the word biopsy, see, a biopsy is the first stage for us to confirm. They get frightened. What I understand, because when you talk to a common man, biopsy means cutting, taking, when they feel that the cancer is going to spread. So you must be seeing these kind of myths that So many people might not come because they are frightened. Biopsy ante na దగ్గర నుంచి తీసిస్తారు, దాని నుంచి spread అవుతుంది. So how do you imagine that a patient, how do you talk to a patient, because you have such a big facility? So a biopsy has to be done. How do you explain to the family how it is done and why it is done?
Yeah. So many times even now we see patients who are scared to get biopsy done, or when we inquire about the advanced nature of the disease, they say we were scared to get the biopsy done. So in general, for general people understanding, we call it as a tumor doubling time, which is actually 4 to 6 months in many of the patients in any cancer, solid cancer. So the cancer generally they don't spread that fast. It will take 4 to 6 months for 1 gram of tumor to become 2 grams. And it won't spread with the kind of biopsy, any kind of biopsy. And in general, unless there is an open ulcer, even we don't do a open biopsies. Then most of the biopsies at this point of time we do with an ultrasound guidance or CT guidance, a small needle biopsy gun where it takes only 1 millimeter of width of the tumor and it goes straight into the tumor and comes out, and the tumor will not spread because of the biopsy. So that is what we keep telling the patients and keep telling the doctors also, and in our continuous medical education programs wherein we address the general MBBS doctors and other specialists, non-oncology specialists. So very few conditions where we don't advise biopsy is an ovarian tumor, which is in the form of a cyst. Where you do biopsy, it will get ruptured, and it becomes from stage 1 to it can become stage 2 or stage 3. Likewise, pancreatic cancer, testicular cancer, ovarian cancer, these are the tumors generally we don't advise biopsy, because kidney cancer also. Because once there is a tumor there, the chance of it being malignant are more than 90%. Then whether it is cancer or non-cancer, the treatment is same. So then in those conditions we don't advise biopsy, and those conditions where we expect complications because of the biopsy, a kidney tumor, you do a biopsy, it may bleed because of the vascularity. In a brain tumor, sometimes because of the inaccessibility, sometimes we don't do biopsy. Straight away we plan for a surgical procedure. Apart from that, all the tumors should be biopsied, should be treated only after the biopsy, because biopsy is very important not only for the diagnosis. Understand the nature of the tumor, biology of the tumor,
the origin of the cell.
Sometimes actually what is the cause of the cancer in that particular patient. Either the treatment modality also can be decided basing on the biopsy. Sometimes we don't advise surgery at all if the biopsy suggests that the patient should get radiotherapy or chemotherapy. So it's not about the diagnosis, it is about the treatment decision itself will decide on the biopsy itself.
But when do you decide as a surgeon to cut? See, now a tumor is seen and you don't know whether it's benign or cancerous, but treatment has started. When do you decide to actually remove the organ? See, some treatments, the organ still remains, the diseased organ, and then chemotherapy shrinks it, or whatever happens. But as a surgeon, when do you intervene and say, no, we need to cut it first?
See, most of the times, all the solid tumors, many of the solid tumors, they get cured only if you do the surgery. If the disease stage is not stage 4, up to stage 3, unless surgery should be a part of the entire plan of the treatment, they can't get cured. But there are international guidelines wherein when to do the surgery, when not to do the surgery, when to do chemotherapy or radiotherapy first, then do the surgery. There are standard guidelines. We follow the standard guidelines, but mostly by NCCN guidelines and ESMO guidelines. There's so many guidelines we follow, and most of the practices in oncology are multidisciplinary now. So every patient will have a consultation with a multidisciplinary team, like a medical oncologist, surgical oncologist, radiation oncologist, nuclear medicine doctor, an anesthetist, and a plastic surgeon, wherever it is required. Then we will plan a personalized treatment protocol for that particular patient, basing on the biopsy report, stage of the disease, nature of the tumor. Then we'll do a tumor board. In that, all the doctors will decide what is the treatment protocol for that particular patient. It doesn't mean that each and every patient will go to the tumor board, because some protocols are confirmed and we don't need a tumor board for certain cases.
Those are common.
There are very standard protocols.
Okay.
Wherever there is a confusion, wherever there is a doubt, and there is a particular this patient should be treated beyond the protocol, then only all those patients should be brought into tumor board, then we treat.
Doctor, very often we hear stage 1, stage 2, stage 3, stage 4. What is the difference? I mean, people say, oh, stage 4, oh my God, people react. So, and commoners, a mistake, we ask, yes, stage, and what stage? Because we don't know, we only know that they are dangerous stages. What are these stages?
Cancer diagnosis is different and stage is different. So many people come with the biopsy report and they ask us what is the stage.
Correct.
No. The stage is decided by various investigations and clinical examination, and to find out whether the cancer has spread from that particular organ of origin to the lymph nodes, or to the visceral organs like liver, brain, bone, etc. If the cancer is confined to the organ of origin, generally we call it as a stage 1.
Okay.
If it is spread to the lymph nodes, then we call it as a stage 2. When it goes beyond but not to the visceral organs, it is stage 3. When if it is already spread to the visceral organs like liver, lung, brain, bone marrow, bone, then it is called stage 4. In general, there are so many changes between organ to organ, but in general this is the standard thing. But these are all stages for a solid tumors.
Okay.
When it comes to the liquid tumors or blood cancers, the stage system is different.
So, irrespective of whether it's stage 1 or 4, they can be cured. Medication has cured even stage 4, isn't it?
Yes.
So, there are some people who say that, it's okay. For this cancer, even stage 3 can be cured. So, that's very confusing because people think only stage 1 can be cured. But a question I want to ask you here is, can a person have 2 primary cancers at the same time?
So when your question about the stage of the cancer and cure rates, stage 1 cancer, the cure rates are up to 95%. In stage 2, we can cure them up to 75 to 80%. Stage 3, we can cure up to 50 to 60%. In stage 4 also, we can cure certain cancers in stage 4, but the rates vary up to 20 to 25%. So if it is stage 4, the chance of cure drops down to 20%.
But still there is...
yes, there is.
And there is a chance.
Yes, there is a chance, but not for all cancer. There are only certain cancers can be cured even in stage 4, like particularly pediatric cancers. Even in stage 4, we can cure the children because they respond very well to chemotherapy. Likewise, neuroendocrine tumors, even stage 4 we can cure. Liver cancers we can cure. A limited kidney cancers, even in stage 4, if the isolated metastases are there, we can cure. We call them oligometastatic cancers, where the disease burden in the stage 4 area is very, very less. So we can cure those patients.
Yes, yes.
Coming to the next question that you have asked, I forgot.
Can a person have 2 primary cancers?
Yes. The person can have 2 primary cancers at the same time or sequential. Once they get cured, they can always get 5% of the patients, they can get cancer in another area.
But not related to the first
not
cancer.
related to the first cancer. When it happens within same cancer, if it happens within 2 years, we call the recurrence. But if it happens after 2 years, most probably it is a second primary. We call them as a second primary.
So that means some patients are more receptive or more, have the capacity. So immunity plays a very big part here, isn't it?
Very, very big role. That is the reason immunotherapy is coming in a big way. Immunotherapy is actually not actually a treatment. Only it boosts a person's ability, immune ability to identify the cancer cell and kills the tumor cell. We augment the patient's immunity to kill the tumor cells. That is called immunotherapy.
It's already what is inside your body,
Yes.
and that you make it stronger so that it can identify.
Yes.
Doctor, how does this immune cell identify? This is cancer cell, that is non-cancer cell.
See, patient's immunity is very important. While we are speaking, the cell division is happening everywhere in every body. There is a possibility, though it is a perfect system of cell division, there is a possibility of small problem can happen in the cell division. A rogue cell can come, but our body has got that ability to identify the abnormal cell and repair the damage or kill that particular cell. There lies the immunity role, wherein our body can identify all the normal cells within our body basing on the antigens that we develop during our childhood through the tonsils to the thymus, etc.
Correct.
If the antigen is different, a new antigen is identified by the body, it will identify that it's a foreign cell and it will try to kill. That is the reason when your immunity comes down, the chances of cancer also will be high, particularly in HIV patients.
Correct.
They get more cancers and more lymphomas because
They're
the body
susceptible.
cannot identify the abnormal cell and allow the cell to grow.
Very sad, very sad. If you're watching and you're interested in what we are talking, subscribe to Meet Meenamma. Doctor, I want to take the case of Navjot Singh Sidhu. I mean, it's a big case and people have talked about it. In this case, Mrs. Sidhu actually went through the entire chemotherapy and the whole treatment. And then when her husband joined some media house, I don't know whether it was tweaked or whether he really said it, that, you can absolutely cure even a third and fourth stage patient with lifestyle changes. And he suggested, some neem juices and things like that. What was your opinion when you heard about this case?
So, in my opinion, because either the diagnosis is wrong, maybe the person may not be having cancer, and so that she got cured. But as a doctor who knows about the cancer etiology, cancer biology, and the standard tests, and how the allopathic treatment happens. So without treatment for the cancer, the chance of cancer getting cured is very, 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 very less. So considering the history in this particular case, the person received chemotherapy and proper treatment, so that must have worked very well for her. Sometimes even to get the cancer cured without treatment, it will take some time. Even if you give radiotherapy now, it doesn't mean that at the end of the chemotherapy the cancer dies. The radiotherapy works for some more time. So radiotherapy or chemotherapy cannot kill the normal cell or a cancer cell which is dormant in the tumor itself. So the chemotherapy or radiotherapy, they will take some more time, and it damages the cancer cell. And when the cancer cell tries to divide again, that time that is not capable of dividing and it will die. So it may take some more time for the chemotherapy and radiotherapy to kill the abnormal cells which are already treated. So it must have happened in such a way where the cancer was lying there physically on investigations at the time of completion of the treatment, or it must have got cured with that. But all these supportive care, good diet, antioxidants, probiotics, so many supportive measures will help the cancer treatment to treat the cancer or cure the patient. So it must have been an incidental thing where their observation was like that, or he may be very upset with the treatment what he has received for some other reason in particular hospital. So probably he was trying to tell, that's the only thing, but nothing can be explicable like that.
So alternate therapies can be alongside, but biopsy and a regular chemotherapy or radiotherapy is a must. So for patients who think that alternate therapy alone will help them, they're taking a chance. So it's better that we follow the regular therapies and then augment it with alternate therapies. Is that way? Doctor, patients who come to your hospital is always so full. Do you see more male or female patients with cancers?
So more or less they are all in equal numbers. Statistically, this side, that side. Males are more common because they get more amount, we get more number of oral tobacco chewers, smokers, etc. In women, breast cancer is more. In rural women, cervical cancers are more. So more or less, same. And breast cancer is the number one cancer, even crossed beyond lung cancer across the globe. But still, oral cancer is the common, and lung cancer is the second common in India.
I was reading somewhere that in women, the gallbladder cancer is a very dangerous cancer and very common in northern Indian women. Have you come across in South India also women with gallbladder cancer?
In South India, the gallbladder cancers are less, and pancreatic cancers are found to be more in number in Kerala because they eat a lot of tapioca based foods, where it is found to be a reason for chronic pancreatitis and cause pancreatic cancer. But in general, gallbladder cancers are not at all common in South India.
Doctor, now that you brought up tapioca, food is a very important part, isn't it? Many people feel if you stop eating sugars, you will cure your cancer. Is that a myth or is that the truth?
It's a myth.
So what do you think about sugars and cancers?
See, in general, we know that sugars cause, it's a lifestyle problem where you eat a lot of carbohydrate or sugar more than what actually we need. So you put on weight, and and when you are putting on weight, then you have a more chance of getting cancer. Because we know that after the tobacco, alcohol, the third commonest cause of cancer is obesity. The obesity happens in those patients, those people who eat lot of carbohydrates, who has lot of sedentary lifestyle, not exercising commonly, not maintaining a regular, body weight. So all those things are very very common, and that's a third common cause of cancer. So the eating sugar cannot cause cancer, or after getting cancer, stopping sugar
It's
cannot
not
cure
going to
the
help you.
cancer.
See, people stop eating sugar, but they eat a lot of fruits. They think fruits are good. So patients, people visit patients with fruits. But I believe one apple is equal to 20 grams of sugar. So a sweet apple. So it's not good actually, but sugar, I mean, it's not fruit. Doctor, you've seen so many cases last 25 years and you're such a well-known doctor. Tell us one case, a very special case close to your heart, where a patient and doctor interaction has touched your life.
Particularly, we see many patients, particularly pediatric patients, children. So families are so much attached to the parents, particularly when they cross 5 years of age. So most of the time, many of the times, either they come within stage 3 and stage 4, and particularly in some blood cancers, particularly in children, we see that, kind of an reflection and patient satisfaction and surprise once we treat the patient and patient gets cured. So that gives an immense satisfaction to us, and at the same time, that relationship between the family and the doctor also will be very very long. People think that is a good hand and
He's a lucky hand.
and all those, but that is not the thing. It's a right time, right patient, right stage, and the right treatment as per the guidelines can cure many of the patients. It's
Very
not the
true.
doctor.
But when you enter a operation theater, if there is a child or a patient, who enters the room? Does Murali Krishna, the human being, enter the room, or does Murali Krishna, the oncologist, surgical oncologist, enter the room? I mean, do you see a clear distinction as to who is seeing the patient?
See, as far as we are concerned, when we see the patient in the clinic, so that's the most important part of the entire treatment, because the initial counseling is very very important. Giving that kind of a right information and sufficient information to the patient and the family to encourage them to go through the treatment, and talking more positive about the results than the negative side of the results. So we can always talk about 70, or we can always talk about the negative 30. So that empathy is very very important. We have to push the patients through the treatment with helping them, not to treat those incurable patients and all. So till that time, we have to be more of a human being than a doctor. So we have to empathize. We have to see that every patient is. We take decisions thinking, imagining that they are our relatives. Once we enter into the operation theater, then every patient is same. Once they are under drapes, be it a poor patient, rich patient, middle
See, even
class,
President of India is there, he's still the same.
everybody is same under the drapes.
Very true, very true. Doctor, now with artificial intelligence coming up in such a big way, precision target prone surgeries are happening. Tell me, in cancer cure and your kind of surgeries, how much do you use artificial intelligence?
In cancer, right now, in cancer screening, we are using artificial intelligence, where a typical breast cancer with thermography or non-thermography techniques, where we are not taking any mammogram to the rural programs, where now we are only using digital breast examination devices which use artificial intelligence for identifying those abnormal cases. Second thing is cervical cancer also is like that. The visual inspection of the cervix and the artificial intelligence will pick up the abnormal areas and doubtful cases. Then we bring those patients to the institution and do a biopsy. Like oral cancer, if you just see a phone-based artificial intelligence device, where the device itself will give you the information, this is the case you have to look into, and it will guide us where to do the biopsy also. The cancer may be somewhere, maybe we are doing a biopsy somewhere else. So in artificial intelligence is playing a very big role in the rural programs, and we doctor don't need to, no need of doctor going there to the rural program where a trained person can go and do the pictures, and the artificial intelligence will give the doctor the report, and doctor will call that patient to the hospital. Second thing, we use artificial intelligence is 3D mammography, wherein even if the doctor misses, the system will identify the point where you have to take care of this particular area is not looking good.
Yeah.
And the third thing is in diagnosis, in pathology, in radiology, we can use a teleradiology, telepathology for a cancer diagnosis and identification of the cancer patient who is in rural area. Through artificial intelligence, we can diagnose sitting in the urban tertiary centers. Then we use artificial intelligence robotic surgery. When we operate, the system will give you a lot of visual information and non-visual information also while we are operating. Here you should not go, here you should go, like this. It's a very, very powerful supporting tool at this point of time. Now, predictive analytics are coming in a very big way, where if you put the data of the patient's family history, age, risk factors, smoking history, all these things if you fill, then it will give you a possibility, what is the possibility of risk of you developing some cancer or some heart problem. So predictive analytics also coming up. Now we are using gene testing the genes of particular normal individuals, and we can identify those abnormal cells where we have to be careful,
the capacity for them to change
the cancer, and keep them under active surveillance. We don't treat them, but we put them under active surveillance or screening. And there are so many things are coming up, wherein genomic studies, multi-omic studies, then telemedicine, then quantum technology is coming in a big way in the diagnosis and the treatment also. So the things are changing every month. New guidelines are coming, and every 1 year the technology is being changed.
And so these are all non-invasive. Patient has comfort. There is no prick, there is nothing. It's just a machine that's evaluating you and 100% correct. And then what is the doctor's role after that? During a surgery, I understand there are some countries now recently, a doctor from a remote area has done surgery for a patient in another area. I mean, it's marvelous. It's a miracle how that happens. So what is the importance of a doctor in this time? Because the robot is doing everything. The precision is there. It's all, target specific. But the doctor is a human being in another location far away from the patient. What is the role of the doctor at that time? How important is the doctor versus the robot?
So doctors are important because in robotic surgery, the robo is just, we call it as a robo, but it will not do the surgery unless we operate it, only we operate through the tools.
Correct.
So with the finger movements, we simulate the movement of the instrument in the system, then it operates. We use all the energy sources, instruments, but human only will be doing the surgery. Robo cannot do the surgery. It's only an instrument or a technology.
It listens to the command of the doctor.
That's all. So, and whatever you are talking about doing the surgery from some place to one place is called tele-robotic surgery, wherein same technology should be available there and same machine should be available here also. Right now at this point of time, it's being done morely for teaching purpose. Second thing is very rare surgeries where only one person can do, but he cannot travel to the location where he will assist these people to do the surgery. But there should be one more robotic surgeon should be there here also. It doesn't mean that he can operate without a robotic surgeon here.
Tell me, how expensive are these surgeries now? I mean, cancer therapy is expensive. And many companies don't insure. Very few insurance companies come forward. But there are people who won't want to do therapy unless they're insured. If they're insured, they don't mind. You must be seeing this. What's the psychology of a patient versus insurance and surgery or therapies?
Yeah, there's a lot of change because the decision making or the push of the family to get the treatment done varies. When they are getting the different and when they are getting the treatment from their own source of funds, or when they are getting the treatment from the government sources, or when they are getting the treatment through insurance or a charity. So there's a significant difference in the behavior, even in corporate patients where the company is sponsoring the treatment, they completely behave differently. And when the company is not supporting them, they completely, because of the resources,
Correct.
availability of
It's difficult.
resources.
Difficult.
The availability of resources. Because the treatments are costly in the beginning days of any technology. But with the time, all these things are becoming cheaper. If you take medical oncology, the drug will be under patent for 10 years. Once it crosses 10 years, the generics will come in 1/10 of the cost. So during that time, naturally, for a drug to get developed, it will cost $20 billion for that company. So they have to recover that particular money so that to become generic. So even robotic surgery is costing only 2 lakhs, from 2 lakhs to 5 lakhs or not more than that at this point of time in Vizag. But it varies from city to city. But US and all very expensive.
The system itself is expensive. Doctor, prevention is better than cure, especially in cancer. So we know that your genes can also dictate whether you will be a cancer patient. You have a propensity because you're genetically inclined, but your lifestyle is the biggest villain. So today we see younger people also getting cancers. We see people who are exposed to lifestyle diseases. What is your advice to people who are watching on how they can, are there some ways in which we can save ourselves or at least protect ourselves from the fact that we can also be a cancer patient sometime?
Ultimately, genetic change is the 100% genetic change is required for anybody to develop cancer. Whether it is coming from the family, the hereditary in the like BRCA1-2 mutation in a breast cancer family, or a genetic any familial cancers. Otherwise, all these cancers which happen in regular normal life because of the lifestyle, all these causes will cause a genetic mutation in a cell, which causes an unregulated
A rogue cell.
unregulated division of the cells, which ultimately end up in a tumor and spread to the entire body and kill that person. So genetic change though is mandatory for any cancer cell to develop. But these are all acquired things like history of smoking,
Yes.
alcohol, tobacco chewing, wax, infections, and lifestyle changes. Lifestyle like your sedentary lifestyle and not doing exercise, not taking proper food and balanced diet with antioxidants, etc. All these things will cause cancer. And aging. With the age also, the cancers increases. Most of the cancers we see after 50.
It's
Or
because
60.
susceptibility has
Because of the age,
reduced.
with aging, the genetic changes what can happen over the years, they accumulate in a body, where at some point of time the balance tilts, where your body cannot stop a normal cell to become malignant,
Rogue cell.
and at the same time it cannot identify the cancer cell, or cannot control through its normal immune mechanisms. Some people may develop diabetes at the after 50.
Yeah,
So all
certain
those things
things.
can cause cancer.
Tell me, what is your advice to those who have a recurrent problem? Many of us have a problem, but we don't see a doctor because we think it's normal. It's a common cold. It's a fever that recurs, but I get okay. What is your advice to people like us? Do we do an annual checkup? Or what is the routine that we should follow to keep cancer at bay?
So we have standard screening guidelines for all people at various ages and different sexes. Because if you take women, the standard guidelines are every women should learn how to do a cell breast examination from 20 years of age. A clinical breast examination, whenever it is possible, when they go to a gynecologist for regular checkups.
Yeah.
And a 3D mammography from the age of 40 years of age for breast cancer. For cervical cancer, once they become sexually active, they should get an HPV DNA pap test. If it is negative, once in 5 years, they should get it done. Likewise, that cancer cervix guidelines are there. A person after 40, if they are not smokers, they should get an annual checkup with X-ray chest itself for lung cancer. If the patient is a smoker, a CT scan of the chest without contrast, like how we used to get HRCT in COVID times. Then colon cancer, if it's very common in that particular country, the stool test and or a sigmoidoscopy is a very simple test we can do. If the person is having some symptoms which can suggest, which are suggestive of that person is having some cancer, they should get a regular test like upper G endoscopy, CT scan of the chest, mammogram. They are all selective. What we are talking about screening. A person man above 50 years of age, they should get an annual prostate specific antigen test.
The PSA, that is
PSA.
only a blood test,
Blood
isn't it?
test, yeah. So these tests which are commonly available, commonly done in a routine annual health examination, they are all available everywhere. But people are not getting these tests done on a regular basis because they want somebody else to pay for it.
Is the cancer cell a perfect cell? He never dies. He keeps growing, isn't it? That is what a perfect thing is, model. Do you think a cancer cell is a perfect cell or an imperfect rogue?
Naturally imperfect rogue.
Imperfect rogue.
Can be controlled.
He can be controlled. So what is your advice to students, like how, when you go back 25 years and look at Murli, where you were, how inspired you were? You had a good father, you have a wonderful father. But many children might be looking at cancer, whether it's a probability for them to get into oncology, and that to surgical oncology. What is your advice to students of medicine? Why should they take surgical oncology as an option?
The demand for oncologists will be always be there because number of cancer cases are increasing and technology, science is developing because no one can have the complete knowledge of all the treatment modalities. No one can be an expert of all. Even as a surgical oncologist, I cannot be an expert for treating from brain tumors to skin tumors. So only at some point of time we have to get into a separate field. Like I operate mostly head and neck cancer, breast cancer and soft tissue, bone and some gynecological cancers. So some people train in lung cancer, brain tumor. So subspecialties are coming. A huge opportunity, huge potential for any surgeon to become an oncologist. It's a huge demand is there and a requirement also is there. But only thing is, unlike earlier days, one should not become a doctor. In my idea is one should not become doctor to earn money.
Correct.
There are better ways to earn money, better professions to earn money nowadays better than doctors. Unless you have a passion towards medicine, passion towards treating patients and saving lives, passion to, interest to see the gratitude in, patients' eyes, so you enjoy it. So that is the thing, that is an additional thing, main thing what you get, and money always follows. But
Yes.
if you are good, empathetic, follow evidence-based medicine, do a good networking and good team person, and treat every patient as if they are your family members. Take all decisions thinking like that. Then with lot of satisfaction, money, name and fame will follow 100%. But not for money one should not become a doctor.
And now I can understand why you were such an awarded doctor. See, I have watched you at work and how sincere you are, and also the kind of social service that you do. It's incredible. It's inside and outside the hospital also. And the way in which you come out and talk about the awareness, the programs you do on the Vizag beach, on different parts of, whether it's a World Cancer Day, you're always there, Dr. Murli. You're always in the front. The word cancer and Murli is standing right in the front, and that makes you a very, very special brother and a leader. And I'm sure the government and the whole country is looking at cancer as a thrust health factor, and that is why whether it's Chandrababu Naidu Garu or the health ministry in the center, cancer has been in the top priority list, and India is doing very well. And for us in Visakhapatnam, whenever we say cancer care cure, Voona Muralikrishna's name comes first. It's an automatic thing, and I thank you so much, Murali, for what all you do. You're a wonderful, amicable human being. You're a versatile singer. You're an artist. You're a good speaker. But above all, you're a great human being. I really thank you for being here, and I'm sure that all those who are watching have got lots and lots. There's so much I can talk to you. Lots of information. And for all those who are watching, cancer is all about that one cell that became a rogue. In life, we see all of us cannot be perfect. All of us have imperfections. Don't get frightened. For every rogue, there is a bully teacher. There will be a person who will come and control that rogue so that tomorrow we can feel safe even when the rogue is around. So whether it is cancer or whether it is real life, there will always be heroes like Dr. Muralikrishna who will come and save us. Remember, cancer is curable, it's preventable if you detect it early. So if you have a doubt, reach Dr. Murali or any other oncologist around, trust them because they are the only ones who can guide you correctly. I hope this was very useful to you. Don't forget to subscribe to Meet Meenamma so that I may be able to bring more people like Dr. Voona Muralikrishna and give you more information on beautiful topics. Take care and stay